Ashish, are you there?
Yeah, hey Anil, how are you? So
How
great
are
to
you?
see
Good to
you.
see you. Hey, you lost a lot of weight, man. What's it?
I've lost some
Working
weight, but
out.
it's all good.
You've been
It's
working
all
out,
good.
huh? Oh,
Just managing this uh,
pandemic.
diabetic. No, diabetic. So I'm a
Oh,
non-insulin dependent diabetic because of a strong family history. So on good treatment, I think I've lost some weight. Some of it due to metformin and Jardians, and then rest
ah,
of it is working out. Rest of it is working out for sure.
all right.
Great to see you, and thanks for seeing
Yes.
everybody. I wish I could be there, and I wish we could go back to normalcy. So I think you guys have all brought it up and have laid out the stage perfectly for what I'm thinking is the next step. To make a diagnosis is one thing with a non-hyperemic pressure index or with a all the indices that Ajit presented, or even with the old-fashioned FFR. But the next game in the next step in the game, if you will, is to act, because I think that what we're missing is post PCI assessment, and define GPS is going to answer that, and because 20% of cases that have a PCI that we think is adequate angiographically, even if we've identified the right lesion by physiology, still is not a complete result. And patients have recurrent angina, and oftentimes we're perplexed as to why that is. And the bottom line is that I think we're not doing a good enough job. And I think hopefully this presentation sheds some light on how we can further perform precise PCI and improve outcomes, not just to pick up lesions that need to be treated, but use it iteratively during the case to help optimize your results. So let's start with the case. As you know, it's always the best learning opportunity. So this was a 58-year-old guy that was referred to me, about a couple of weeks ago, and he'd had previous intervention to his LAD and CIRC in 2015. He underwent a myocardial ischemic perfusion scan, which is ischemic both in the LAD and the inferior lateral walls. His ischemic mass on the LV was estimated to be 20% or so. His EF was 45. He undergoes coronary angiography at another facility. They referred him to surgery. The surgeon turns him down because he feels like he's got a poor LAD target. And then he was referred to me for consideration for potential PCI options. So before that, I'm just going to show you the angiograms, the 3 angiograms, and then we can ask some questions and keep it sort of interactive. I'll ask Anil, and then Anil can sort of delegate the questions and see how other people would do things, since I don't have access to the names of the other members of the panel. So here you go. This is the AP column view. This is the LAO cranial view. And this is the right coronary artery. Okay, so we'll move on to what I would then consider, how would you approach this patient? He does have a diagonal artery CTO. Unfortunately, that doesn't really project as well in that iliocranial, but believe me, he does. So how would you treat this guy is the question, right? I mean, nothing jumps out at you as being clearly ischemic. Nothing jumps out as severely narrowed angiographically. And so, Anil, what would you do?
Let's have Ajay. Ajay, well, how would you like to approach this?
So, Dr. Ashish, is it possible to look at the magnitude of ischemia in the various territories? You said you had a nuclear medicine scan that showed some percentage of reversal.
So it was 22% total of the LV mass. I didn't have it broken down.
Yeah, if you have a distribution, that might help us.
No, don't have that.
Right, then probably the next way to go would probably look at the FFR of all the 3 vessels. I think the ripcord had shown that there's a significant discrepancy between the visual assessment angiographically and the functional assessment. And I would actually look at the options for revascularizing the diagonal, because that is a definite CTO, and probably begin the decision from there. It also appears to be gross microvascular disease. So, it's IMR is something that I'm fond of. It's possible to do. We'd actually like to. That's why I wanted to look at the nuclear medicine scan, because it will tell us a great deal about how much of the ischemia is distributed in which territory.
That's a great point. That's a great point. I mean, I think that the bottom line is I think nobody here should be fooled into believing that this is intermediate disease all along. And that would be something that one would get tempted to do if you were just believing in angiography. And the bottom line is I think that's a thing of the past. I think using
if you did not have a nuclear scan and you'd got this angiogram done, most of us would have put this patient up for medical management, for optimized medical therapy.
Exactly. I mean, that's fine. That's the challenge we run into every day. And look how high risk the scan is.
22% ischemia is actually a confounder. But anyway, I must say, I would love to have this interactive, but I've been just told by the organizers that the live cases are getting ready. So let's go on. We won't bug you too much.
Yeah. So in general, my principles of revascularization are as follows. I mean, I would want, when I revascularize patients, the goal is to get a residual syntax of less than 8 based on, the syntax data that was clearly dichotomous at an 8. Obtain comparable results to surgery, we have to give up doing angiography-guided PCI alone. It is just not enough. And then combining anatomical and physiological surrogates is really important, but it requires multiple, not one, multiple IFR and IBIS measurements during the case. And then the beauty is, as interventionalists, we have the luxury of staging procedures. And the beauty is that's the advantage over surgery, because we can use that and treat 2, 3 out of lesions at one time and then bring back, for example, if you have lesions that are left behind, either due to considerations for contrast or for treating chronic total occlusions. So here's the way I approach this. We did a quick IFR of the right coronary. The IFR was completely normal, not surprising. The lesion doesn't look impressive at all. And I had the wire distally down in both the PDA and PL, just in case somebody felt like I was only assessing the proximal vessel. And once you got that squared away, then the big first question I looked at was the lesion in that first OM. The first OM was not even considered in the whole scheme of coronary revascularization with bypass surgery. But with PCI, we have the opportunity to take care of lesions, in some ways even do better than surgery when it comes to quality of life and symptom relief. Sure, taking care of a small OM is not going to impact his life expectancy. I mean, that's obviously hinges on left main, LAD, and proximal disease, but it can be pretty bothersome with angina. So bottom line is, make sure that you don't forget about vessels that look smaller than 2.5, because we have stents now with late losses of 0.1, 0.2 that allow you to treat lesions in the distal vasculature with comfort and with ease. And so here's a case where we initially now were treating a vessel that we thought was essentially untreatable with angioplasty other than with POBA or a drug-eluting balloon. But here we are deploying a 2.5 drug-eluting stent all the way into the distal OM. Again, it's really important to visualize this in 2 projections to make sure you have full balloon expansion, full stent expansion, because otherwise you're going to be left with a big problem. And here you go. The first OM now is completely revascularized. And now we're still focusing on that second OM. I typically will buddy wire with the IFR wire, put in IFR wire after I've put in the workhorse wire, the idea being I can normalize in the aorta so that I don't invoke any false positives related to proximal disease within the left circ or even in the left main or LAD. And in this case, where is a significant lesion? You can't really tell. The only thing we know anatomically was 6 years ago, it had a stent in that distal OM just proximal to the radioopaque marker within the wire. So on the right panel, you have both wires and you did an IFR pullback. The IFR was 0.87, which is positive, and the pullback got a clear spike right distal to the previously implanted stent. And within the stent, it has that big spike. And you know that that's the problem. So this is what was missed on IBIS. So the same image using combination of anatomy and physiology here demonstrates that distal stent, this plaque distally, and boom, you have this. A clear example of an underexpanded stent within calcium. This was 6 years ago and is now positive. It probably was positive then. It was never assessed. And then proximal disease is all intermediate. So that was that focal underexpanded region within the stent all the way down right distally past that small dinky branch of that second obtuse marginal. Again, knowing what to do with an underexpanded stent is important. Luckily, we have lithoplasty now and could use that for management of in-stent restenosis from underexpansion within a calcified segment. Here it is, a 3/0 vessel fully expanded with a fresh stent implanted distally within plaque using the ultimate IVUS criteria as to where you would land it. And lo and behold, boom, here you go. You have the IFR is normalized now, but now you have some haziness proximal to where that lithoplasty balloon was. And you can see using intravascular ultrasound, we identified that there was a edge proximal dissection. And so had to tack that up with a 3/5 fresh stent. And this is your result after getting both the proximal and distal stents and lithoplasty of the previously instented segment. And your IFR is now at least within the normal range at 0.93. So here's how you complete your assessment at the end of intervention. What about the LAD now? Similar situation. The LAD has a stent in the proximal segment, diffuse disease distally, and where do you start and where do you stop? And this question happens and is asked every single day. You also see that diagonal CTO on the right panel, which is a relatively small vessel with a non-ambiguous cap, but I don't see any distal filling. So I chose to leave that alone completely. I didn't think that was playing a role in what's going on. We managed the edge again using imaging. Clearly, the IFR was strongly positive. The image on intravascular ultrasound, in the interest of time, I've not shown it, but had lesions both proximally and distally. The proximal lesion, using that MLD max algorithm that describes morphology, length, and reference vessel diameter for deciding pre-procedure outcomes, is 4 millimeters for proximal segment, 2.5 millimeters for the distal segment. The instented segment had a 3 and a 3.5 millimeter blood vessel that needed a lot of neointimal hyperplastic expansion with an NC balloon and a scoring balloon. And that's what that shows. Didn't really have any issues. Again, the pre-IFR was 0.8. The post-IFR was 1, demonstrating an acceptable outcome within the vessel. So the takeaway for me in 2021 is angiography guided or IVUS guided PCI is not enough. And the interesting thing is that post-PCI FFR is superior to even the residual syntax score of 8 that I quoted earlier in differentiating the risk of target vessel failure. And this comes from the post-PCI FFR registry, and clearly with a log rank p-value that was highly significant. So my takeaway is that some form of post-PCI physiology is absolutely mandatory. If you wanted to use a chart in your lab, this is a good chart to follow. I essentially would do a non-hyperemic pressure index after you've finished. And if the results are acceptable, you're done. If the results are not, then usually the non-hyperemic pressure indices, for the reasons we mentioned earlier, are more susceptible to false positives and negatives related to the enhancement of flow after repeated balloon dilatations that you get as a reflex, as well as more susceptible to alterations from no reflow or situations like that, especially when atherectomy is used concurrently. In those circumstances, I think going to a FFR assessment is probably required. And then if the FFR assessment is adequate, then you're done. If the FFR assessment is inadequate, then it becomes the big elephant in the room as to whether there is focal disease or diffuse disease. Before we incriminate IMR as being the only issue related to unsatisfactory outcomes with PCI, we have to invoke the potential consideration of diffuse disease. And I think there's going to be a lot of work done in the next few years related to the delta FFR post-PCI in the segment that was treated versus that was left behind, to determine what percentage of the lesion ischemic burden comes from the lesion that was treated versus the rest of the artery that has what looks like intermediate disease. Or another way,
Ashish, I would hate to interrupt you, but we are getting reminders that the live cases are ready. You've invoked some great points, and we all realize that one of the greatest studies that has come, which has made us think, is the defined PCI study, which tells us that 1/4 of patients that we take out after a PCI are probably not done enough. And you've made this point truly, truly eloquently. So we thank you for the time, for the consideration, and we'll now move on to Ajay. And Ajay, can you just make a quick presentation, because the organizers are telling me that the live cases are absolutely ready. Great case, Ashish, and great to see you present something other than CTOs.
All right, sounds good, buddy. Take care. See you around. Yeah, bye. Take care. Bye.